Dr. Nidhi, you can switch on the video. We'll start the meeting now. Yeah. So, good morning and welcome to Saturday Club meeting once more. Today we have a very interesting topic to be discussed, and that is atypical manifestations of acute viral hepatitis. A very common entity, but Dr. Nidhi will share some of her experiences regarding some atypical presentations. To introduce Dr. Nidhi Saini, she is a pediatric gastroenterologist working in Baroda for so many years now. She had her DNB pediatrics from Mahatma Gandhi Missions Medical College, Navi Mumbai. Then she had her PDCC, Fellowship in Pediatric Gastroenterology, and senior residency at a very reputed institute of our country, that is Sanjay Gandhi Postgraduate Institute, Lucknow. And she has special areas of interest in celiac disease, Wilson's disease, and portal hypertension and pancreatitis. She has several publications to her credit. She is affiliated with very reputed institutes in Baroda. And above all, she is a very popular speaker. She is always a very looked after, sought after speaker when it comes to pediatric gastroenterology. And in fact, she is not new to Saturday Club of Baroda. When Saturday Club of Baroda meetings were held offline physically, we had her on quite a few occasions sharing her experiences. So welcome Dr. Nidhi Saini to Saturday Club, and you can start your talk now. You will have about 45 minutes of talk, and then we'll have 10 minutes of interaction. Thank you.
Thank you, sir, for the kind introduction. I'm glad to be back at Saturday Club. I'll just start sharing my screen, right? So is that visible, sir?
Yes, very well visible.
I'll start?
Yes, please start.
So good morning, everybody. As sir already mentioned, the topic for today is atypical manifestations of acute viral hepatitis in children. Starting right away. So give me a moment, my slide isn't moving.
No problem, no problem.
Yeah, right? Yeah. So a few words on acute viral hepatitis. So in simple words, hepatitis is inflammation of the liver. To objectively classify it, any elevation of liver enzymes more than or equal to 3 times the upper limit of normal is called as hepatitis. This could be an acute illness, self-limited, short-lasting illness for a few weeks with complete recovery, a chronic illness lasting a few months to years, culminating into cirrhosis or end-stage liver disease, and a very rapidly progressive fulminant liver failure requiring either liver transplantation or leading to death in a matter of a few days. As we all know, viruses are one of the commonest causes of acute hepatitis, both hepatotropic like hepatitis A, E, and B, as well as the non-hepatotropic viruses like dengue, varicella, CMV, etc. Some non-viral illnesses like typhoid, leptospira, rickettsia are also known or notorious to present with hepatitis. Other than viruses, drugs are a common etiology that we see in our setting, paracetamol or acetaminophen being the commonest, antitubercular therapy like isoniazid, rifampicin or pyrazinamide, anticonvulsants like valproate, prolonged use of antibiotics like ceftriaxone or amoxicillin clavulanic acid, and uncommonly chemotherapeutic agents. A very sick child, a physical insult, or a severe sepsis may present as an ischemic hepatitis. Uncommonly, Wilson's disease and autoimmune liver disease may also present as recurrent jaundice or hepatitis, and even more rarely as a fulminant liver failure. Some systemic illnesses like collagen vascular disorders, autoinflammatory syndromes like an HLH or a macrophage activation syndrome can rarely present as hepatitis. Now, why did I choose this topic? So this is a very simple graph, and as we can see in this graph that there are 4 lines which are all going in the downward direction. So this is the WHO data over 15 years from 2000 to 2015, which says that the prevalence of deaths due to HIV, malaria, and tuberculosis is persistently on the decline. However, deaths due to hepatitis per year has been persistently increasing. Now, in 2019, the WHO published the data saying 325 million people are diagnosed with hepatitis so far, and this is probably just the tip of the iceberg. Now, why atypical? The last 2 years have taught us a lot of new things, a lot of infections that had taken a backseat during 2 years of the pandemic. Now, hopefully towards the tail end of the pandemic, we do see a sudden surge of multiple other infections, whether that is tuberculosis, dengue, typhoid. And this, as we can see, is a newspaper publication with a large increase in liver abscesses post-COVID, which has not only been seen by us at Baroda, Gujarat, or India, but has also been seen globally. They also have atypical presentations or deviation from the natural course of the illness. So whether that is in terms of the duration of the illness being very, very long, or uncommon manifestations of a common illness. Mechanisms of all these atypical presentations, multiple postulations, lot of research ongoing in COVID. So whether there is a dysregulated host gene or immune response post-COVID, we have probably tried everything under the sun for COVID, whether it is antibacterials, antivirals, antiparasitics, immunomodulators, micronutrients, everything has actually been attempted. So whether polypharmacy or use of multiple drugs leads to any increased predisposition towards these infections is also a postulation. One more reason why I chose atypical manifestations is more often than not, I am the second point of contact with the patient. So I'm going to give you a slightly biased view, as in nobody is going, I would not be seeing a very typical case of acute viral hepatitis. So my experience as to when we can just let go versus when we need to chase very vigilantly and treat uncommon or atypical manifestations of acute viral hepatitis. So with this background, we'll see a few case scenarios, some true, some hypothetical, and what is specific or common to our scenario in Gujarat or Baroda in specific. So case number one, we have a 7-year-old boy who presents to us with fever, anorexia, and vomiting for a period of about 2 to 3 days. Uncommonly, parents may often say that they may present with a sensation, a vague sensation of being unwell. They'll come to you and say, "Saru nati lagtu," or "Theek nahi lag raha hai, kuch karne ka ji nahi karta hai," these manifestations. And all of us, most of us do eat outside at some point in time. So that is mostly there in all case scenarios. At this point in time, our differentials would be, it could be an acute gastritis, it could be a beginning of an acute gastroenteritis, acute cholecystitis, appendicitis, and number of differentials. With time, or over the next 2 to 3 days, all these symptoms often become passive, and then we notice a yellowish discoloration of the eyes and the urine. This is when the child most typically presents to us, and we suspect an acute hepatitis in this scenario. On examination, the child has mild jaundice, a soft hepatomegaly, and rest of the systemic examination is normal. So this is on investigations, we see a mild hyperbilirubinemia and an SGOT and SGPT around 1000. So this is how a typical case of acute hepatitis or an acute viral hepatitis presents to us. An important word of caution here would be that our investigation does not stop here. It is of utmost importance to chase the underlying etiology for this elevation of bilirubin and the enzymes. And as we already discussed, the commonest cause of acute hepatitis in children would be a viral hepatitis, and that too hepatitis A. Seeing the natural trend of acute viral hepatitis, we may have a prodromal phase which will last somewhere between 0 to 7 days, a symptomatic or an itching phase of jaundice which may last somewhere between 1 to 3 weeks, and a resolving phase which may last somewhere between 3 to 4 weeks to as long as 12 weeks. Important point to note here is that younger children, especially those less than 5 years or even 2 years, can sometimes present with an anatric illness. So they are just detected with a vague sensation of not feeling well, or the child is having anorexia or not accepting well. And on investigation, we may find that the enzymes are very high. However, as the child grows or in the older age group, more patients are likely to have symptomatic or ectric jaundice, as we say. With this background, we'll see the second case with a slight modification. So we have the same 7-year-old boy who had fever, anorexia, and vomiting, followed by jaundice. But now, with the onset of jaundice, the anorexia has subsided. The child is eating well, but the fever after an interfebrile period has recurred. Now, fever is not an atypical manifestation, but it is often a very troublesome manifestation for patients, and that is what brings the patients to us. He is otherwise okay. The jaundice also tends to start decreasing, but the fever is there. Now, we can segregate this into two arms. One is if we have a proven etiology, that is an acute viral hepatitis, or A, E, B, some marker is already positive. Mild to moderate grade of fever can last for up to 5 to 10 days in patients of acute viral hepatitis due to an ongoing necrosis. But if we have not proven any viral marker to be positive, or we do not have an underlying etiology, we may want to look for other causes. There's a huge list of other causes, but we are going to have some telltale signs or some evidence to suggest other causes. So as we saw, the commonest causes are hepatotropic viruses. Now, on clinical examination, if we find any rash, cervical nodes, or if the child is on immunosuppressants or long-term medications, we may want to think of atypical viral illnesses. Drugs would be a common factor. As we saw, entry or leptospirosis in our setting would also be of utmost importance in patients who have both fever as well as jaundice. We may want to then start looking for liver-specific causes or primary liver disorders if we do not find any cause among the above mentioned. So a few words on fever in acute hepatitis. As I said, mild to moderate fever may persist even in acute viral hepatitis due to an ongoing necrosis. Co-infections, uncommonly liver abscess with right upper quadrant tenderness may present with fever. Atypical malformations like biliary obstruction or a choledochal cyst, and a child who is getting sicker with each passing day may have macrophage activation syndrome or hemophagocytic lymphohistiocytosis. Moving on to case number 3. So this is a 3 or 3-month-old child. The onset was again very typical, a prodrome in the form of fever, anorexia, and vomiting. However, this was followed by jaundice with high-colored urine for 8 days. And there was no history of lethargy, irrelevant talk, altered sensorium. Basically, there were no features to suggest a hepatic or encephalopathy, no past or family history of jaundice, and he was the only child born of a 3rd-degree consanguineous match. Now, on examination, the child had the picturesque fetal edema, a hepatosplenomegaly. To note is the spleen was almost 4 centimeters below the costal margin. Now, this child presented on day 6 to the pediatrician, had mild anemia, hemoglobin of 8.7, an elevated conjugated bilirubin, and the liver enzyme around 850. So the child was reassured by the pediatrician that this is a Mausam ka Kamla or an acute viral hepatitis, explained all precautions to take rest and sent back home. However, 2 days later, the patient came back with an increasing jaundice. Our investigation showed that there was a drop in hemoglobin from 8 to 8.7 to 7, an elevation in the total counts, and the bilirubin had jumped from 7 to 20, whereas the enzymes were almost the same. Now, a fortunate thing or something that would be relieving is a normal INR. One point to emphasize here is that the most important investigation in this entire panel would be a PT-INR. That is, PT-INR is the most important investigation as far as severity of acute viral hepatitis is concerned. Now, the child was hospitalized, and after 72 hours of supportive treatment in terms of hydration, analgesia, pain relief, the parameters were repeated. There was the hemoglobin was more or less similar, but the bilirubin had further shot up from 20 to 27. And there was a borderline elevation of the retic count, suggesting some ongoing hemolysis. Now, at this point in time, we had three concerns. That is an anemia or a drop in HB without any overt loss, some evidence of hemolysis in terms of the elevated retic, and a rapid rise in bilirubin with the decreasing enzymes, which is an ominous sign for any patient of acute viral hepatitis. So the child was started on choleretic supportive management and supplements. A viral marker was sent, which was again positive in terms of an HAV IgM. When we have any patient with a rapid rise in bilirubin or anemia, we may want to look for an underlying hemolytic disorder or renal insufficiency. A peripheral smear, a hemoglobin electrophoresis, G6PD enzyme analysis, renal function tests, and urine were thus set. Now, this child fortunately gave us the diagnosis in the first go. The hemoglobin S, or the sickle cell hemoglobin, was 65%, and the diagnosis of sickle cell disease was confirmed in this patient. Retrospectively, the parents then revealed that the mother was already a known case of sickle cell trait, and the father was a case of sickle cell disease on hydroxyurea. Whether we did not elicit it properly or the patient had a fear or was in a denial mode that I am already suffering from it, so why should my child suffer? Had we got this history before, probably things would have fallen a little more into place. Before we know what happens to this case, we'll see another similar case scenario. So now this was an 8-year-old boy who presented in the emergency at midnight during the pandemic with a history of fever, vomiting, and pain abdomen for 1 day. The child had a history of decreased activity and lethargy for a couple of hours and difficulty in breathing for an hour. Now, the difference between the previous and the above this case is that this patient was already diagnosed with sickle cell disease at 4 years of age. So he was on hydroxyurea and folic acid. However, as in all chronic illnesses, he had defaulted for a period of 3 months. On examination, the child was very restless, was anemic, had deep icterus, had tachypnea and tachycardia. The liver was not palpable. Again, another ominous sign, and the child had a huge splenomegaly for a child of sickle aged 8 years. The reflexes were brisk, but rest of the examination was normal. So the resident medical officer on duty at night thought that this is probably a case of sickle cell disease who has presented with an acute crisis. He started all the supportive management in terms of hydration, analgesia, broad spectrum antibiotics, and a blood transfusion. The investigations at admission showed pancytopenia, which could also be due to hypersplenism, considering the child had a massive splenomegaly. The CRP was very high, had a bilirubin of 9 and 5. An SGPD of 44 was very reassuring for the resident that he's not really dealing with liver involvement per se. Electrolytes, creat, and chest X-ray were normal. Now, this case had presented in the MISC wave, as we may call it. There were a lot of waves of COVID, but there was one phase during the pandemic where any patient who came to us did not fit in with a typical illness. Our minds would start thinking of MISC, or probably the fear that we may not miss an MISC. The COVID PCR of this child was negative. Unfortunately, the COVID antibody was strongly positive. So this child was thought of as a post-COVID MISC. But fortunately for us, all the supportive or paraphernalia investigations were not convincingly supportive. The child continued to have fever over the next 10 days, 1 to 2 spikes per day, sometimes low grade, sometimes high grade. The pain was more or less passive. The child did not have obvious features of encephalopathy, but was never normal, always sleeping, dull, and in the background, the jaundice was persistently increasing. See the trend of investigations. The bilirubin, which was 9, gradually creeped up to 30, 35, and the SGPT, which was 77, shot up directly to 2,750. And the INR, which was previously not done because the enzymes were normal, was 3 or uncorrectable even after vitamin A. The viral marker sent was positive. So now here we had a case of acute liver failure with cholestasis, which was due to an acute viral hepatitis. Once the bilirubin starts shooting beyond 30 or it rises very rapidly, in a case of sickle cell disease or hemolysis, that may be an exchange, that may be an indication for an exchange transfusion. By the time we could even plan the exchange, the bilirubin further shot up to 49. Now, it was not only the patient who had tachycardia, but also the treating consultants. So this patient then underwent 2 sessions of plasma exchange. This was followed by a gradual decline in bilirubin to 8. The enzymes fell, however, the albumin fell also from 3.4 to 2.9. This child had a stormy course during the hospital stay, lasting almost 40 days, but glad that we could discharge him at a relatively normal state in the resolving phase with improving investigation. There are 2 coins to these 2 cases that we have seen. Number 1 is prolonged or severe cholestasis in patients with acute viral hepatitis, and the second entity that is very peculiar to us as in comparison to the rest of the country would be sickle cell disease and cholestasis. So this was a case of an acute on chronic liver disease, that is acute liver failure with cholestasis with an underlying sickle cell disease. A few words on the hepatic manifestations in sickle cell disease, or what we call as sickle cell hepatopathy. This is classified as various syndromes. Liver is the commonest organ to be involved in sickle cell disease. There is a broad spectrum of manifestations ranging from mild elevations of bilirubin, fluctuating hypertransaminasemia, and acute hepatitis, sometimes leading to an acute liver failure. Microvascular lesions like intrahepatic infarcts leading to liver abscesses, gallbladder and CVD calculi leading to biliary obstruction and even biliary pancreatitis, which qualifies as an emergency, drug-induced liver injury, iron overload, and the severe end of the spectrum, acute hepatic sequestration crisis or the sickle cell intrahepatic cholestasis. Now, we already know that patients with sickle cell disease have an increased predisposition to gram-negative infections like Salmonella, E. coli, Klebsiella, but there is some literature to suggest that these patients may also have an increased susceptibility to viral infections. So when we have cholestasis in acute viral hepatitis, it could be either severe cholestasis or prolonged cholestasis. So we define prolonged cholestasis as a bilirubin of more than 10 and lasting more than 12 weeks. This is the commonest atypical manifestation in patients with acute viral hepatitis, but this is one of the most troublesome manifestations. Patients often have intense refractory pruritus. I've seen parents come to me कि एक तरफ से वो खुजाता है, एक तरफ से हमें बोलता है कि तुम खुजाओ. He or she has such intense itching. But this is labeled as in isolation due to acute viral hepatitis in the absence of hemoglobinopathies, hemolytic anemias, as well as renal insufficiency. We know that a serum bilirubin of more than 17 is a poor prognostic marker. A rapidly rising bilirubin with decreasing transaminases is an ominous sign, and coagulopathy, irrespective of the level of bilirubin in itself, will also qualify for acute liver failure. Moving on to the next case, a slight modification in comparison to the previous. So here the fever seemed to be passive, the sensorium seems to have improved, but the jaundice is gradually rising over the next couple of days. And here the child has recurrent anemia requiring repeated blood transfusions in a period of 1 week. So it's on one side, we seem to be giving transfusions, and on the other side, the hemoglobin does not seem to increase. Now, obviously, we've already seen 2 cases of sickle cell disease, so this is not sickle cell anemia. When we have a case of anemia in acute viral hepatitis, what do we want to think? A simple urine examination or a urine color may sometimes give us a clue that a cola-colored urine means probably an intravascular hemolysis is ongoing. Now, what could be the causes of anemia and acute viral hepatitis? Hepatitis A is in particular very notorious to trigger autoimmune disorders. That could be an autoimmune hemolytic anemia, an autoimmune liver disease could be unmasked, or an autoimmune thyroiditis could also be. Bone marrow suppression in any form, plain anemia, bicytopenia, or pancytopenias can occur post acute viral hepatitis. This child in particular had G6PD deficiency. So if we have anemia with an elevated retic count, we have a male child in particular, we may want to make sure we do not miss an acute episodic trigger of G6PD deficiency. A child who is getting sick with persistent fever and increased requirement of blood transfusions may have auto-inflammatory syndromes like macrophage activation or HLH. You may not want to then miss any underlying hemoglobinopathy like sickle as we saw, or an underlying chronic liver disease like autoimmune liver disease, or Wilson's, a fulminant Wilson's can sometimes present with a Coombs negative hemolytic anemia. Moving on to the next and my last case. So again, this patient had a very typical presentation. The onset was typical with fever, anorexia, vomiting, and pain abdomen, followed by an increase in jaundice. But by day 6 or 7 of the illness, the child started developing abdominal distension, periorbital puffiness, pedal edema, and some evidence to suggest pleural effusion. So by day 6 of the illness, the child had ascites, which could be of varying degrees and may even manifest as anasarca. On investigation, we find that the albumin is low. Now, we know that the half-life of albumin is 21 days. So if we have any child with acute viral hepatitis who comes to us with 3 weeks or 4 weeks or 6 weeks into the illness and the albumin is low, that is fairly acceptable. Second, any patient with acute viral hepatitis, 30% of them may have ascites in the early phase of the illness. A few common causes are, we often admit these patients, we succumb to the parents' request on giving glucose and continuously administering IV fluids. That happens to be one of the commonest reasons why a few patients may present with mild or moderate degrees of ascites. However, none of these patients actually have massive ascites or tense ascites requiring therapeutic paracentesis or large doses of diuretics for a very long time. But if we have any patient who presents with massive ascites in the early phase of the illness, we may want to make sure we're not missing out on any underlying chronic liver disease. We are going to get some evidence of the same in our history as well as the investigations. So as we said, as I said, we may have an early onset ascites, poor growth parameters, a recurrent history of jaundice, either in the patient or in the family, would suggest either a Wilson's or an autoimmune liver disease. And uncommonly, when we get a history of antenatal pruritus in the mother, a young child presenting with recurrent episodic cholestasis with pruritus, progressive familial intrahepatic cholestasis is an upcoming entity, which we may not realize on the first go, but when such patients come to us repeatedly, we've not been able to prove a proper underlying etiology in any of the cases. This is often an underlying etiology. A family history of liver disease, neuropsychiatric illness, or autoimmune disorders. These could be an autoimmune thyroiditis, a type 1 diabetes, even vitiligo in the family members. On examination, we may find that the child has acute and chronic malnutrition, some stigmata of chronic liver disease in the form of spider angiomas, paper money skin testicular atrophy. We may have a very firm liver in contrast to the soft, tender hepatomegaly that we find in patients with acute viral hepatitis. There may be a left lobe hypertrophy, and there may be a disproportionate splenomegaly. A spleen palpable of around 1 to 3 centimeters below the costal margin is routinely felt in our normal patients. But if we have a spleen of 4, 5, 6, or a spleen which is palpable right up to the umbilicus, we may want to think of some associated or other disorder. With this, this is a recent literature from India, published about 3 years ago, of atypical manifestations of children presenting with sporadic acute viral hepatitis. 477 patients were retrospectively analyzed over a period of 12 years, 2000 to 2012, and they found that 22% of patients had atypical features of acute viral hepatitis. The commonest manifestation that was found in almost 50% of their patients was prolonged cholestasis, that is cholestasis lasting for more than 12 weeks. The second was ascites, as we saw. Others may be an IV hemolysis. This could be associated with an underlying hemolytic disorder or IV hemolysis in isolation with acute viral hepatitis, relapsing hepatitis, as in a waxing and waning course. So we may notice that the bilirubin is for once returned to normal, but there may be a relapsing course, which could be in a duration lasting anywhere between 4 to 16 weeks. And acute pancreatitis. So hepatitis E is very notorious to cause acute pancreatitis, and last was thrombocytopenia. There are some other manifestations, atypical manifestations, which were not seen in this study, like in acute glomerulonephritis, which we recently saw in one of our centers. Vasculitis, arthritis, dermatitis are three other atypical manifestations of acute viral hepatitis. Among all the underlying viral etiologies, hepatitis A most commonly leads to any atypical manifestation, and that is what we see even commonly. This is followed by a co-infection. We may unfortunately not know this data because most of our patients we stop when we find one viral marker which is positive. And any academic setup, it may be possible to look for other markers in patients with atypical manifestations. But in the kind of setup that we work, sometimes financial crunch may not allow us to send all the investigations. So these are multiple studies from India, which again showed that the prevalence of atypical manifestation ranges somewhere between 3% to 50%, as high as 50%. Now, having said this, it is probably very easy for me to say that these patients present with atypical manifestations. This child has a prolonged jaundice. This child requires recurrent blood transfusions. But if we think of it from a parent's perspective, it's very difficult for them to accept that a simple illness like acute viral hepatitis is making them undergo such a torture with a prolonged hospital stay and repeated blood transfusions. That too because of an illness which is probably entirely preventable. So this was a very small but relevant editorial written by a pediatric gastro colleague that is timed right for hepatitis A vaccination in India. So data as far as 2019 is concerned shows that each year around 126 million cases of acute hepatitis are seen, and 35,000 deaths occur due to acute hepatitis. Hepatitis A may account for as high as 90% of cases of acute liver failure, with a mortality as high as 30%. So the question is time right for a mass vaccination? The hepatitis A is qualified as, countries with hepatitis A are qualified as high, intermediate, and low endemicity areas. High endemicity areas is where most of the children, or 90% of children by around 10 years of age, are seropositive for hepatitis A. So in such a scenario, there may not be a lot of meaning of vaccinating all the children, but India is now falling from the high endemicity to the intermediate endemicity area. That means the age prevalence of hepatitis A is probably climbing from the younger children to the older children. And as I already mentioned, these atypical manifestations are more common in older children, adolescents, or adults. So probably we are at a phase where mass vaccination or including hepatitis A in the universal immunization program may be worth it. Having said that, there are 2 vaccines which are available for hepatitis A, but are they cost effective? Are a vaccine which costs somewhere between 800 to 2000 rupees possible to be included in the UIP? Maybe not. If not, what we can do is, at least in all our patients with chronic illnesses, whether that is a patient with nephrotic syndrome prior to starting steroids, a patient who has been diagnosed as sickle cell disease, a patient who has a chronic liver disease due to any etiology other than a viral illness or a chronic hepatitis B, we may want to vaccinate these patients, because such patients are going to have an increased propensity to develop an acute viral hepatitis, and these illnesses, they will be doubly troublesome for the patient or the child. That means the hepatitis itself is going to be more complicated or will have a prolonged course as well. And in addition, the primary disease progression may occur even faster. So concluding my talk, acute viral hepatitis is a major public health problem. We may want to make an utmost effort to delineate the underlying etiology, because when we have patients with recurrent such episodes, that could be due to an underlying chronic liver disease. Moreover, 2 common causative agents, hepatitis A and B, are vaccine preventable. Even vaccines against hepatitis E are now available in some countries. Most of these patients recover in 3 to 6 months. Atypical manifestations may occur in as high as 1/4 of pediatric patients with viral hepatitis. We may not want to immediately evaluate for an entire list of causes causing chronic liver disease, but we may want to make sure that we follow such patients over a period of 3 to 6 months to demonstrate resolution of the organomegaly. And another important point is we do not chase the SGOT, SGPT after every 2 weeks or 3 weeks or 10 days. But at the end of 3 months or 6 months, we may want to document the normalization of enzymes so that we are not missing any underlying chronic liver disease, which is probably tolerant. I think with that, I will end my talk.
Thank you, Dr. Nidhi. You can stop sharing the screen now.
Yes, sir.
Wonderful, very informative presentation. With very typical of Dr. Nidhi is that she doesn't talk without case illustration. So it was very good to have few cases also here as an illustrating point for your presentation. There is a question from Dr. Hemant Sant regarding occurrence of hepatitis E. How common do we see that?
After hepatitis A, hepatitis C is the second commonest cause of an acute viral hepatitis, more commonly in an older age group. That means above 5 years, 8 years, or rather above 10 years. Hepatitis E may be more common in comparison to hepatitis A. However, recently, with the change in endemicity, we have been seeing Hep E even in younger patients as old as 2 years. So if we follow the order, which is A followed by E, and uncommonly, even B is known to occur and present as an acute viral hepatitis.
So Dr. Nidhi, in a typical case of viral hepatitis, what are the various markers that we should ask for?
So first line investigations would be an LFT. We may want a complete LFT, which may be serum bilirubin, SGOT, SGPT. Now, we often land up chasing serum bilirubin and SGPT. But if you ask me one important marker or one important investigation that I would want and that would give me relief would be an INR. We do not often do this, but an INR of more than 2 is going to make me very vigilant that this child can deteriorate at any time. The second most important investigation in any patient is sometimes when we see an SGPT of 1500 or 2000 in a walking child, we tend to take it for granted that this is an acute viral hepatitis. I may not want to stop here. I need the underlying pinpoint etiology. Is this a hepatitis A? Is this a hepatitis E? If my typical markers are negative and the child is giving me some atypical signs, then we progress to the atypical viruses or other illnesses. And uncommonly, as I said, we may want to then see whether the child is harboring any chronic illness.
So to put it in other words, you will not look for viral markers in all cases of hepatitis, or will you?
I will, yes, sir. I will. So in a typical presentation, I say, for example, a child coming to me with fever, vomiting, anorexia, and an enzyme and SGPT of 1000. My first investigation is going to be an anti-HAV IgM.
Okay. Because these tests are costly, so we may not ask for a series, battery of them, but one by one we can do.
Yes,
right?
Yes. We may want to, ideally, or if we are sitting in an academic or a research institute, we may want to send all of them, but where we practice or in a private setup, we may want to send them one by one.
And Dr. Janardhan, sorry?
I had 2 questions, Nidhi.
Yes, sir.
When will you do plasmapheresis? You did in one case.
Yes, sir. So we have been very fortunate that we now have the advantage of KGP probably is that we have an entire team and the administration is again very supportive. The third case that we saw was a little before Dr. Jalpa had joined in. So that time we had done a plasma exchange in these patients and not a plasmapheresis. But the case with sickle cell disease who had a bilirubin of 49 would ideally be a candidate for plasmapheresis. The principle is that a very high bilirubin, a sickle cell disease, is probably due to oxidant damage and antibody-mediated damage. So though it may not cure the disease per se, but it is going to bring down the antibody load or the load of the antioxidant or load of the oxidants that is there. And thus, any patient with sickle cell disease and acute liver failure, irrespective of the bilirubin, a very high bilirubin, particularly more than 30, or a very high HbS of more than 30, again, are all indications for a plasmapheresis in patients with an acute viral hepatitis. In addition to that, other disorders like a fulminant Wilson's or an acute liver failure, now there is increasing evidence to say that it may not only act as a bridge to transplant by the time we can transfer these patients to a transplant center, but in anecdotal case reports, they have often obviated the need for a transplant.
So Dr. Janardhan has been looking at your presentation very keenly, and he wants to know what is the final diagnosis second case.
So the diagnosis was clear, sir. It was sickle cell disease. We had an HbS of 65% in the child. So that was again sickle cell disease. Now, sickle cell disease, we stay in the sickle cell belt. So during my residency, I never saw such a case. When I saw a bilirubin of as high as 49, even I was taken aback. And but sickle cell disease itself is very notorious to lead to severe or prolonged cholestasis. So it was sickle cell disease with acute viral hepatitis due to hepatitis A.
Dr. Nidhi, viral hepatitis is a very self-limiting illness, but we see a lot of therapies being used. So I would like you to give some messages on what not to give, like say UDCA, etc.
So no medication is actually required in any case of acute viral hepatitis or the typical self-limiting illness, which is seen in 90% of patients with acute, 90 or rather 95% of patients with acute viral hepatitis. My only recommendation is rest at home, adequate hydration, and a simple multivitamin. The second part of the question, what not to give, there is no role of UDCA in every patient of acute viral hepatitis, unless he or she presents with cholestasis, a rapidly rising bilirubin, a value of more than 10, or pruritus. So every patient of UDCA, we do not give cholestasis. The second common medication that we give is Livfit or the Ayurvedic or the herbal preparation that is available. We are not the right people to comment on such medications, but in the last 2 years, with the use of these alternative medications, there has been a rapid increase in drug-induced liver injury. So in an already compromised liver, we may not want to attempt any alternative preparations. The next commonly used medication is silymarin. Again, there is conflicting evidence to suggest that it may or may not work. And as per literature, in certain studies, there has also been shown worsening in the natural course of the illness, especially in younger children. So I would refrain from doing it. One more common thing that parents do is that this is not related to medications, but in a child who already has an acute viral hepatitis, you tend to go to the outside lariwala person and get shedi ka ras or sugarcane juice, which is going to add on to our problems because we do not know the hygiene of that sugarcane juice, with all due respect, but that is not going to help. So I absolutely tell my parents against this. One more thing that we do is give excessive fruit juices. That is again not recommended. Apple, Mosambi, all kind of juices are given. They actually may worsen the disease progress because juices are extremely hyperosmolar. So having no food and 4 glasses of juices and fruits just make the child going to vomit, and he may not eat anything, and that is going to be interpreted as a complication of acute viral hepatitis. Last and foremost is giving bland food or giving a bland diet. No salt, no haldi. So that is again the biggest myth that is available. What I would recommend is giving a plain and a simple diet, what we eat at home. So none of us tend to cook or overcook in oil. I wouldn't recommend having a fried puri or a bhaji at this point in time, but a roti, vegetable, dal, rice is going to be the best diet for a child.
Right. So you already answered one more question from Dr. Sulin, and that was regarding diet. Now, Dr. Sabnam is asking about how to control high-grade fever at home. And she is specifically asking about mefenamic acid.
Despite all the odds and despite paracetamol causing liver failure, the safest drug in fever with acute viral hepatitis is paracetamol. It is not NSAID. We always avoid giving a combination of ibugesic and paracetamol commonly available. Now, we know that mefenamic acid, we do not find many reports of mefenamic acid causing acute liver injury, but that is because we do not use it so commonly and it is not reported well in literature. But again, mefenamic acid will never be my first choice of medication. As far as possible, 10 to 15 mg per kg per dose of paracetamol 6 to 8 hourly is the recommended dose in patients with acute viral hepatitis. In low grade fever, for example, fever less than 100 degrees Fahrenheit, we may just want to use normal water compresses.
Right. I think there is a overhyped toxicity of paracetamol is overhyped because we don't see paracetamol toxicity in our setup. It's mostly in the Western world where people consume excess of paracetamol as a suicidal drug also. So you will agree with me that paracetamol is a very safe and very benign molecule for giving for fever as an antibiotic.
I would agree, sir. In fact, if we compare data from West and us, paracetamol poisoning happens to be the commonest cause of even acute liver failure. Whereas if we see the Indian data, it is viral hepatitis and paracetamol comes very low down. 2 scenarios where we may want to suspect paracetamol poisoning. Now we are all aware of that difference is drops versus syrup. So if we have a younger child, we know that 1 ml is 100 mg in that, whereas 5 ml is 125 mg in that. So in case we write a syrup and the patient lands up giving drops, can add on to the confusion. And accidental administration of a simple versus the double strength dose, which is given repeatedly, are the 2 scenarios where we suspect paracetamol poisoning. But otherwise, viral is way more higher in comparison to paracetamol poisoning.
Right. And then there's a question by Dr. Sulin regarding use of vitamin K. Do you use it in all patients?
So this is a slightly controversial question. As a gastroenterologist, where I predominantly deal with acute liver failure or chronic liver disease patients with a correctable vitamin K deficiency, my first instinct is that any patient with acute viral hepatitis who comes to me, I may want to administer the vitamin K, at least one dose, and we send off the PT-INR. Ideally, what we should be doing is we send a PT-INR when the child comes to us. If that is normal, we may not want to give the injectable vitamin K to that patient. One very uncommon or rare scenario where vitamin K could cause harm, or I would specifically avoid vitamin K, is in a child with suspected G6PD deficiency. So there it can worsen the hemolysis. So the answer to this question would not be yes or no, but in a child who is walking with a palpable liver, happy, playful, typical, I may not give it. But in a child with early encephalopathy or suspected acute liver failure, yes, that would be the first drug that I would give. And word of caution, it's never to be given subcutaneous or IM in this child. It should be administered intravenously.
So what is the picture when you get a hepatitis in case of a G6PD deficiency patient?
Often G6PD we know presents in two forms. One is a chronic subgoing hemolysis or an acute episodic hemolysis. Acute viral hepatitis is known to trigger that acute episodic hemolysis. Again, 2 years back, we've seen a case who presented with a bilirubin as high as 38. So they, again, G6PD and acute viral hepatitis may have a severe cholestasis, a very high bilirubin, and recurrent anemia requiring blood transfusions.
So that should be one of our differential diagnoses when we deal with very high bilirubin.
Yes.
Then there is a question regarding comorbidity of typhoid and hepatitis together. So Dr. Sabnami is asking how safe it is to use ceftriaxone.
So in a child with, there are two ways to look at it: hepatitis and fever, and hepatitis and culture-proven typhoid. So if I have, say, rising titer, a child with continuous fever over 10 days, a rising titer of Vidal, or a culture-positive typhoid and a culture-positive Salmonella typhi, I would go ahead and give the ceftriaxone, because I know that the fever is due to ceftriaxone, and that is even so far the first drug of choice for typhoid fever. But in a case with hepatitis and fever without a focus, and I'm just dilly-dallying over whether it could be typhoid or not, I may want to avoid giving ceftriaxone. I may rather want to opt for giving maybe a cefotaxime or an alternative medication.
Thank you. So there are no more questions in the chat box. If there are any comments from the audience, you are welcome. There are some physicians also, I see, if they would like to share their experiences about hepatitis, viral hepatitis in their practice. So thank you, Dr. Nidhi, once again for accepting our invitation at a relatively short notice of 1 week. And as usual, no, we all really enjoyed your cases and a lot of information that you shared with us. So thank you very much. And we look forward to some more talks by you in future. So thank you all.
Sure.
We end the session here. We meet again next Saturday, where we'll have Dr. Hardik from WHO will be talking about the management of tuberculosis under NTEP in adults. So we meet again next Saturday. Thank you all. We end the session. Thank you.
Thank you.